Hey, I'm Mike Larson. I'm an assistant professor of radiology at University of California, Davis. I'm going to go over ultrasound-guided hernia repair based on this publication, as you can see here by Dougherty et al., published in 2024. Before I get to this is a medical disclaimer. I'm not giving medical advice. I'm not establishing a doctor-patient relationship with you or anything. This is just my review of this paper. So the equipment needed will be a diagnostic ultrasound probe, a hollow needle, generally 18 gauge because 20 gauge is kind of too flimsy, and the length and bend or curvature will vary depending on the body habitus and hernia size. You'll need suture. In theory, anything size 2 or smaller can fit through an 18 gauge needle, but the publication specifically used 2O Proline. You'll need a pointed scalpel, such as like an 11 blade. Wall section will be needed to pull suture through the hollow needle and forceps to secure the suture. So before any procedure, we've got to talk about indications and selection factors. So a hernia must be ventral, not inguinal, not have anything critical going in through or around it. And it needs to be readily reducible. The adjacent fascia and muscle to the hernia must be intact, so no loss of domain. So I'm going to diagram this. At the bottom, you can see I have the skin is kind of orange, subcutaneous fat is yellow, the muscle and fascia layer underneath that is dark red, and then the visceral fat or the hernia sac is dark yellow. Not shown, the hernia sac doesn't have to just be fat. There can be bowel within this, according to this publication. And then on the far bottom right, you'll see the longitudinal orientation. So step one is prep. Identify the hernia, sterile prep skin over the hernia area, and then kind of optionally, you can load suture into a bent or curved hollow needle of adequate length. Mentioned it before, 20 gauge is too flimsy. The authors skipped the step of preloading their hollow needle with suture. And then you can see in the bottom middle, that's kind of the transverse ultrasound probe on there, and then the bottom right shows the longitudinal view. So key important to this is to make a tiny incision at what we're going to say is the left and then right aspects of the skin overlying the hernia. Obviously, this could be the superior and inferior or whatever. The orientation doesn't exactly matter, just that there are two tiny holes where you can direct needles in and out of. Next, they placed a hollow needle through what we're saying the left side of the left incision and along what we're going to say the close side of the hernia, engaging fascia and muscle. So this is a picture straight from their publication. You can see a curved needle going down through skin or subcutaneous fat, and on the diagram you can kind of see that needle comes down through fascia on what we're saying is the close side, so closer to us. Longitudinal view on the bottom right, you can kind of see that the orientation of that needle tract isn't exactly straight vertical relative to the probe. There's a little bit of an angle to it. Next step is to direct the needle out of the subcutaneous fascia out through that right incision. And again, you can kind of see the actual ultrasound picture there on the bottom left, my diagram in the middle, kind of showing that transverse plane, and then the longitudinal view of the needle tract. So then you're going to pass the suture through that hollow needle, and this is where suction might come in handy to kind of pull that proline through. Then secure the suture with forceps and remove the needle. So now all you have is a suture going in the left side, in the fascia, out of the fascia, and then out the right side. On one side, unlike what we're saying is the close side of that hernia sac. Then basically they just repeat that hollow needle placement going through that left side incision. Now we're going to, instead of going on the close side of the hernia sac, you're going to go on the far side of the hernia sac, as you can kind of see diagrammed on the bottom right, how that second needle track is going to be on the opposite side. And so they'll place that hollow needle. Again, they're going to pass the suture through that hollow needle and then out the right incision. And again, securing the suture, you can then tighten the suture from you're pulling on it, pulling on both sides of the suture that are coming out the right side, it will squish some of the subcutaneous tissue on the left and kind of bury that side of that aspect of the suture, and close off the hole through which there's a hernia. Obviously, before you do this, you got to make sure you reduce the contents before you pull that tight. And then they basically just did a square knot and tied really tight and buried the knot. And so this is kind of a conceptual summary from the paper of what just happened, just how they fixed these ventral hernias using only ultrasound, a needle, and suture, basically. So again, poke the kind of two critical parts of the most superficial layers. You got to have the tiny incisions where you can go in and out with the needle and suture. Then they have that subcutaneous layer diagrammed, fascia. It's kind of key to grab a little bit of the fascia, so you have something a little more solid than subcutaneous fat to tie down. So I hope that makes this idea of using ultrasound to fix hernias a little more clear. Thanks.